Hello, everyone. Welcome. My name is Barbara Cochran. I'm the director of the Deterny Center for Healthy Aging here in the School of Nursing. And as every Tuesday, today I'm representing the Northwest Geriatrics Workforce Enhancement Center, which is sponsoring this series of geriatric healthcare lectures. I think we're nearing the end. We've got 3 more, and then in spring we will be doing another series of 10 focus on Alzheimer's disease and related dementias. So hope you'll sign up for that. If you have not filled out a personal profile form yet for this series, please contact your site coordinator and do so. Those profile forms are how we are able to report to our funding agency the marvelous things that we're doing so that they will keep funding us and we can keep offering this lecture series. If you're interested in continuing education contact hours, your site coordinators should also have information for how you can log in and pay for, I think it's the $45 that it costs to sign up for the lecture series and then get continuing education contact hours. And that will be offered again in spring term. Today we're really happy to have Jenny Roraback-Carson. She is, I said the Carson anyway. Yeah. She is a geriatrician practicing in the outpatient, inpatient at Harborview Medical Center here in Seattle and nursing home settings. She's also medical director for an adult day health organization that provides services to adults with disabilities, including developmental disabilities, and she's going to talk with us today about geriatric patients with intellectual and developmental disabilities. She's a clinical instructor with our Division of Gerontology and Geriatric Medicine here at University of Washington School of Medicine, and that's housed also at Harborview Medical Center. So Jenny, welcome. Thanks. And thank you so much.
Yeah, thanks. Thanks for having me. It's an honor to be here. I apologize. I have a cold, so I'm going to pray for no coughing attacks. And if you have any issues with sound, let me know. So as it was said, I'm a geriatrician at Harborview, and I do have an interest in this population. I think grew out of my time spent with Full Life Care, which was formerly Elder Health Northwest, which is an adult day health agency in Snohomish and King counties here. So it's been sort of something I stumbled upon just in the years that I've been practicing since my geriatric fellowship. So it's kind of fun to spend this time and talk about it. So we'll start off with just talking about the objectives and give you a brief sense of the outline and what we're going to be touching on. So we'll just start with definitions, right? The definition of intellectual disability, developmental disability, kind of appreciate their differences in etiologies. I hope that we can all understand the common barriers to primary care in this population and know the different forms of long-term care and services offered, including adult day health. We'll talk about the common issues in this population, legal issues, risk of violence, financial exploitation, sexuality, and healthcare disparity. And I also hope that everyone, the clinicians out there, will feel more confident in your approach to the comorbid conditions of these patients. There are many, but sort of the big ones that I wanted to touch on include cerebral palsy, seizures, spasticity, dysphagia, GI dysmotility, polypharmacy, behavior disorders, mood disorders, and dementia and cognitive decline. So obviously trying to cover a lot of ground in the time that we have, but hopefully we can get to it all. So beginning with the definitions here. Developmental disability is something that occurs before the age of 22, persists indefinitely. There is chronic mental or physical impairment resulting in either the delay of or failure to achieve normal developmental milestones. And one of the other defining features is that it causes a significant functional impairment in independent living, or your ADLs, self-care, expressive language, learning, and economic self-sufficiency. And then it's a term that encompasses both intellectual disability and physical disabilities. whereas intellectual disability is more just a broad term that refers to a mental capacity below normal. And there are limitations in both intellectual functioning and adaptive behaviors. And it's due to any cause and before the age of 18, and it replaces the dated term of mental retardation. So the etiologies vary. There's basically the three big ones, either genetic, a brain injury of some sort, or a third of the time we never figure out why. There's no cause identified, especially among our geriatric population when medicine looked much different, maybe in the 40s, 50s, etc. So there are over 500 different genetic defects associated with intellectual and developmental disabilities. Those with more severe disabilities tend to have genetic syndromes, whereas those with more mild intellectual or developmental disabilities tend to have more of a history of brain injury. And the majority of genetic abnormalities are due to Down syndrome or Fragile X syndrome. Brain injury can happen at any time, so prenatally, things like fetal alcohol syndrome, which is the most common, can cause developmental disability. Perinatally, things like infections or trauma, and anything occurring in childhood there before the age of 18 or 22, depending on what disability you're talking about. So metabolic abnormalities, infections, and trauma, and those things are less common now that we address things like hypothyroidism when vaccines have improved over the years. And as I said before, a bunch of the cases, no cause is ever identified. So a little more background. So it affects about 0.6 to 2.5% of the total population. And these folks generally have a shorter lifespan by about 13 to 20 years. And it's due to a combination of forces, but the big one is that there's a thought that there's an accelerated aging process that happens. In this population, there are higher rates of obesity, sedentary behaviors. There's more poor nutritional habits and dental disease. Though they have a shorter lifespan, these people do live longer these days, including those with more severe or limiting disabilities. And for example, those with Down syndrome, they're living twice as long as they did 25 years ago. So these patients are going to be filling the offices of primary clinicians and geriatricians, or filling our hospital beds or nursing home beds, etc. So these patients face a great deal, a lot of threats to their quality of life, from anything from the changes in their body that are happening with normal aging, the inadequate funding for health and social services. It's not unique to just this population, but there's often not enough services to go around. There's a healthcare system not designed for them for either their physical or intellectual abilities. They face a great deal of discrimination and attitudes from our society. They have inadequate access to opportunities to have an active lifestyle and appropriate nutrition. They are susceptible to caregivers who may be burnt out, overburdened, inadequately trained. And for many, as they're aging, they're facing progressive immobility, cognitive decline, often increasing behaviors that will limit their opportunities, their living situations, etc., and their world can shrink. Their ability to engage in their community will shrink. So some of the questions that you may ask yourself when approaching a patient with a developmental or intellectual disability is, how do we approach preventive care and health screening in this patient? Who am I talking to? Who am I communicating with? Am I talking with the patient, their caregiver, their DPOA, their guardian, their nurse, the escort who brought them to the appointment? What are the logistics of care in the clinic or outside its walls? How can we accommodate or meet this patient's needs? How are we going to maintain this patient's comfort, their dignity, their preferences? How can we protect them from abuse, neglect, and exploitation? How are we going to figure out their goals of care and navigate end-of-life issues? And there may be other questions that you all have in your mind when you're thinking about this population, and encourage you to write them down and we could talk about it at the end. So first, I just wanted to touch on the barriers to primary care. So in general, these patients see primary care providers a lot less often compared with the general population. It's due to a bunch of reasons. Big one is there's a lack of primary care providers who are knowledgeable or comfortable with these patients. They may have, they're more likely to have behavioral issues that make examination, testing, or treatment difficult. So then we just avoid it. We don't face it or try to troubleshoot it. There are often big communication issues between the provider, caregiver, or caregivers, and the patient, and breakdown occurs that leads to lack of coordination of care. Physical challenges that make leaving home difficult. And as we all know, a huge shortage of providers willing or able to do home visits. A clinic environment that causes sensory challenges to the patient, from anything from the lighting to the noise to how they're going to navigate the office, just in general, physically. Caregiver burnout leading to missed appointments and things. Shortage of provider time needed to accommodate these patients' needs. As we all know, our RVU requirements don't go down over time, and it's hard to accommodate patients who need longer visits. So I just wanted to bring up a case highlighting some of the first issues I wanted to touch on. So this is a 74-year-old patient with a history of intellectual and developmental delay or disability and type 2 diabetes, cognitive decline, arthritis, and atrial fibrillation on Coumadin. She has a history of 2 falls in the past year and widely fluctuating INRs. She's been living in a senior care facility, whatever that is, for the past 5 years. And with her last fall, she was found down by a friend after 8 hours of long lie. She's been leaving her building less and less as she's fearful of falling and experiencing increasing arthritis pain. So I brought this one up because, and maybe it's more among the MDs that I hang out with, but the different forms of long-term care where these patients are dwelling is often a huge black box for people, and that may not apply to this crowd, but I wanted to touch on how important it is to understand the patient's living situation and just describe those. So in general, patients in this population, as with all of our geriatric patients, they're more living in the community rather than in institutions or SNFs. So they might be living independently in private residence. They may be living with their parents, especially in their more younger years. And of course, as these parent caregivers age and require care themselves and die, it is a major transition and stressor to the patient. And they may be living in an independent living retirement community. So have their own apartment, maybe there's a dining room in the building, maybe they offer some a la carte services like laundry or housekeeping, but it's very variable. So no medical interventions being provided in that sort of setting. Or perhaps they're living in an adult family home. So just so everyone knows, if we're on the same page, 2 to 6 residents will live in a community home. They're licensed by the state. There's often a nurse delegation or supervision by the state, but typically does not have frequent nursing involvement. It depends. Some will and some don't. Some are operated by folks with a nursing background or may even have a valid license, but it's certainly not a requirement. And you know, in general, they're going to provide a room, meals, laundry, supervision, and varying levels of assistance with care. And some offer specialized care, so some may have a focus of dementia care, some may have a focus of younger folks with psychiatric disease, etc. Or some, you know, may have folks who have advancing neurodegenerative diseases approaching chronic ventilator requirement. I mean, the services can be as intense or more intense than what is offered in a SNF, honestly. It just varies a great deal. Assisted living facilities, 7 or more residents, usually bigger than that, in a bigger apartment building. licensed by the state again, varying levels of service. Everything is a la carte, but includes things like an adult family home in terms of med administration and things like that. And then memory or dementia care is one specific type of assisted living facility. And then we have, of course, a skilled nursing facility where there's 24-hour supervised nursing care, personal care, you have therapy, nutrition, activities, social services, room, board, and laundry. And of course, there's federal oversight by CMS and state licensed. There's now a push to avoid nursing home placement for long-term care and instead to have patients in more community settings. And I had to bring it up, adult day health, because of my work there. These are places that provide half-day programs for patients to attend anywhere from 1 to 5 times a week. Sometimes 6, I think. They provide individualized nursing care. There's typically an RN on site. And one-to-one and group rehab services are provided. Social work support is available. There's social programming and sense of community, group exercise, caregiver support and education. It's a grossly underutilized service. Most of the people that I encounter, other practitioners, have no idea what it is. And I never heard about it or learned anything about day health as a trainee. And it serves people who live at home or in other settings like adult family home, assisted living. And it's a great way to supplement the care that's provided in those settings and also provide respite for caregivers. Okay, so back to our case of our geriatric patient. He's got some cognitive decline, has been falling, and you don't know really where she lives because they just called it a senior care facility. And so you kind of clarify that she's actually living in an independent living apartment or low-income senior housing. She has a common dining room and activities, but no nursing care, monitoring, or supervision. And you asked her to bring in her pill bottles and explain what and when she's taking them, and revealed obvious impairments. And you recommended she move in to an assisted living apartment or an adult family home where she could have her meds administered and a personal alert device used, given her fall history. And you also recommended that she begin attending adult day health for fall prevention exercises and nurse monitoring. So let's talk for a second about who pays for adult day health. So DSHS covers day health, the VA covers day health. It goes kind of under the COPES waiver, and but yeah, it's covered by Medicaid, not Medicare. And some long-term care insurance is covered as well, and there's other grant funding often that's available depending on the county or where you are. Okay, so I hope that answers the question. Caregivers. So caregivers come from family. They might be a hired individual or from residential or institutional care setting. The knowledge of the patient and their ability to communicate issues is super variable. There are obviously, we've all encountered them, some amazing caregivers out there. And there are some who just were not born caregivers or are in a role that they didn't choose to be in. And it's something that you have to assess individually with each patient and figure out, how, I mean, that's a whole separate talk, but how you're going to interact with this caregiver and what are the key ways that you can communicate with them to get what you need to know about the patient. Also, there's a lot of disruptions in care, and relocations are really common in this population due to insurance changes, or their care needs change, or behaviors become a barrier in one setting and they need to move to another. It leads to a huge fragmentation of care. So, family caregivers. The demands on these folks are definitely increasing. They themselves are older, so we're asking older, frailer family caregivers to take care of sicker patients. As we all know, these patients are experiencing shorter hospital stays and things, and we're asking them to take on quite a bit of that caregiver burden. And as I mentioned before, the caregivers or the parent caregivers themselves are aging and suffering health decline. So it's important to ask about, caregiver burden at every visit, or at the very least, if you have a social worker available to you, to make sure that that the caregiver is on everyone's radar. And if you're hearing about sleep disruptions or nighttime behaviors, that big alarm bells should be going off in your mind that that issue needs to be addressed and the caregiver needs to be supported, because that is often that's the straw that breaks the camel's back that leads to nursing home placement for folks who are attempting to keep someone at home for as long as possible. And multidisciplinary support is essential. So next I want to talk about patient communication ability and how that plays a role in the care of these patients. So never make assumptions about a patient's abilities. Always assess their expressive and receptive skills when meeting them, and reassess often, because that may change over time. And always address the patient directly whenever possible. I think most people have heard this and know this, but it's always worth mentioning that when you walk into the room, you should be addressing the patient and not the caregiver, that your voice and eye contact is directed to the patient and not the caregiver. And always acknowledge the patient's right to consent and their ability to participate in decisions in whatever way that they possibly can. And it may be something as simple as saying, I understand that so-and-so is the person that's helping you with these decisions, but I wanted to let you know that we've talked about it and it sounds that the plan is X. Always keeping the patient in the loop. And, when communication is limited from the patient, we're often relying on the caregivers for our history. It can be really vague and really limited. So it's always worth your time to try to find the caregiver who knows the patient best. So as I alluded to earlier, you often might be in a clinic seeing somebody who's escorted by someone from a facility, and that escort may, don't assume that they're the one who's going to give you the information you need about the patient. It's often going to require some phone calls to talk to someone who actually knows what's going on. A medical chart is often full of huge holes of information. It's a broken chain. So these patients do require that extra effort to sort out what their problem list is, what's going on with their medications, what's the history of their medications and how they've been changed, et cetera, et cetera. And I already touched on that. And it's important to know that nonverbal or severely limited patients are at a much greater risk for nutritional issues, being over-medicated, suffering injury, and suffering abuse. So these are our most vulnerable patients. And always look for undiagnosed hearing or vision impairment, especially as these folks are aging. Those issues may be overlying intellectual disability that's worsening their communication. So important to always assess for that. And enlist the help of a speech therapist for communication tools or help in any way that they can, which is something that I rely on all the time. So I also want to talk about the value of routine visits. It's really important to have regularly scheduled visits and not to just rely on family or caregivers to schedule visits as acute medical issues arise. Because when these patients aren't able to reliably communicate any new symptoms or problems or needs, we have to pick up on it on a routine basis. So, and these visits are going to require extra time due to the psychosocial issues and also, I would say, simply the physical issues. And half the time in these routine visits, you're going to identify a new issue or diagnosis because of the multimorbidities that's present in these patients, and upon your assessment and digging is when you're going to find new issues. So, one sec so I don't cough, sorry. The next case, excuse me, is about a 66-year-old man with Down syndrome, dysphasia, and Alzheimer's disease living in a nursing facility. He was recently hospitalized for an aspiration pneumonia. He's had progressive decline in the past year. He's always been his own decision maker, but recently he appears to have less of an understanding, of his medical conditions. His pulse form is kind of old, from 5 years ago, currently indicates he's full code with full interventions, meaning intubation's okay. So the legal issues that come up in this population, really important to clarify the issues of durable power of attorney for healthcare or guardianship early. And that said, I'm not assuming that these folks don't have decisional capacity. Many patients do. It's just important to anticipate the need for guardianship or DPOA, and also to anticipate a successor guardian for aging parents. Medical providers often need to become a patient advocate when there's controversy over the approach to care. So there are some settings in which, we are the ones in the room with the knowledge and the perspective that is needed to help guide family or these patients to decisions that we think are going to provide the greatest comfort or meet the patient's needs. I mean, it's sometimes a very delicate issue because this patient may have never been able to communicate a preference. So getting to know the patient and family and really have conversations to suss that out is important. Determining their goals, their code status, or filling out their pulse form should really be done before a life-limiting diagnosis or event occurs. So I always, with my outpatient primary care practice, make sure everybody's got a pulse form on file, or at the very least a DPOA that they've assigned and that we've talked to about their goals. So a note on decisional capacity. And many of these patients with intellectual disability can do these things. They need the 4 elements of the ability to communicate a choice, the ability to understand the relevant information, the ability to appreciate a situation and its consequences, and the ability to reason rationally. And I would say the only other thing to add on that is that they can do this consistently. It's helpful to have the patient paraphrase back to you their understanding, their reasoning. And decisional capacity is not decision specific. So someone may be able to assign a DPOA, choose where to live, but not necessarily be able to decide if they want operative or non-operative management of their hip fracture, for example. And just because they don't appear able to have those 4 elements of decisional capacity when it comes to one decision, it doesn't mean that applies to all settings. As I said earlier, if they seem to lack decisional capacity, you should still discuss decisions with the patient and keep them in the loop. So back to our case of the elderly gentleman living in a nursing home with Alzheimer's, dementia, and dysphasia. You asked if he can tell you what he knows about his recent hospitalization, and did his providers tell him that maybe pneumonia could happen again because of his aspiration. And you asked what he understands about intubation and if he's ever known anyone who was intubated or ventilated. And that's often a question I ask is, have you ever seen someone or known someone or heard of someone who's been on a breathing machine, just to get a sense if they understand it. He was really unable to describe his hospital stay at all. And he was confusing breathing tubes and feeding tubes in the conversation. But he was able to tell you who he would choose as a decision maker, and he's been consistent about that over time. So you asked for help in helping to assign a DPOA, a friend in this case. So sexuality In this population, again, this is a broad topic and can be probably its own separate talk, but it's an issue that's overlooked. And it's often assumed that individuals with intellectual or developmental disabilities are not sexually active, or we make this assumption about geriatric patients in general. One thing to touch on is that we often need to assess the individual's ability to consent. Run into this a lot also with my dementia patients, but it can involve a complex conversation with family. And it's appropriate to provide appropriate STD counseling. I don't think in this population we don't have to worry about birth control, but it is appropriate to screen for STDs. As far as the victim of violence risk, so these patients are at much higher increased risk of physical and sexual violence. Happens at the hands of caregivers or institutional staff or other patients even. And by meta-analysis of 3 different studies, there's about a 60% increased risk for experiencing violence among persons with intellectual disability compared with the general population. And it seems intellectually disabled folks are at a higher risk than other folks with other types of disability like mental illness, physical or sensory impairments. Okay, and financial abuse is also a big one. So it's one of the fastest growing forms of abuse, targeting seniors and adults with disabilities. There's 2 general forms, financial exploitation and financial scams. So exploitation is something that's perpetrated by someone that the individual knows, often family, a caregiver, or a friend. And there's financial scams that we've all come across, and you or I can usually snuff those out and avoid them, but someone with a disability may not be able to make that judgment. Disparity is due to the combination of the increased burden of disease, the communication problems, and inadequately funded support services. They're less likely to receive adequate medical care than the general population, despite their increased burden of chronic health problems. These folks have decreased rates of recommended preventative health interventions. As I talked about earlier, they're also not seeing their PCPs as often. And there's deficiencies in the structure of health services for these folks and funding. So here's a bunch of conditions and issues that I wanted to touch on. So we'll kind of switch gears to being a little bit more clinical. Beginning with cerebral palsy. So CP is just referring to the presence of a non-progressive motor impairment. And like intellectual disability, it's a non-specific term. So not all patients with CP have an intellectual disability, but up to 1/3 of all intellectually disabled patients are affected by CP. Some of the big challenges or issues that are common to CP patients are spasticity and immobility, strabismus and cerebral visual impairment, and bowel and bladder dysfunction. And seizure disorders are also a big one that are common. They're more prevalent in patients with intellectual disability than the general population, especially among the lowest IQ. And about 50% of CP patients have seizure disorders. Seizure disorders or epilepsy have a very high morbidity mortality, with the death rate being 3 times higher than those without seizures. And often more than one agent is required to get control of the seizures, and it's important to monitor for toxicity and side effects. Excuse me. And for those with a long-standing history of seizure disorder, you have to think back and remember that these folks were probably, they may still currently be on or had prior exposure to the medications that commonly cause osteoporosis, including dilantin or phenytoin, tegretol or carbamazepine, and phenobarbital. So especially these older patients, they've been on those meds for years and will have osteoporosis related to that. So also here we have a 69-year-old man with CP, right lower extremity spasticity, and wheelchair dependence. He's having increased spasticity of the right leg, causing some increased pain and decreased ability to participate in transfers. He's been on methylcarbamol for years, and it's really unclear if it's helping. And he was previously followed by a physiatrist, but he's been lost to follow-up many years ago. So spasticity can be really difficult to manage in the elderly population because we're up against the anticholinergic effects of the medications that can cause really high increased risk of falls, delirium, and cognitive impairment. It's great to get help from a physiatrist if you have access to one because they can offer treatments and interventions that as a primary care provider can't, namely Botox injections. And the basics are important, always to remember, optimize positioning and seating, wheelchair fitting, etc. So just wanted to give a little bit of info about the medications that are commonly used for spasticity and give a few little pointers on them. So diazepam and other benzos can be effective, but huge risk of delirium and impaired cognition and falls. So generally, you're going to want to avoid those if you can. Tizanidine is pretty strong, pretty efficacious, but it's really sedating and should be also avoided. Dantrolene can be pretty good, pretty helpful, but it requires some liver toxicity monitoring. And methylcarbamol is generally less effective, and for it to get to an effective dose, the dose is so high that it's really not safe in the geriatric population, so it's also kind of a no-no. And baclofen is less sedating but effective, but has this trade-off of being associated with more muscle weakness. Often, if I'm forced to use a muscle relaxant, baclofen is the one I'm going to choose. Localized injections with Botox are great if it's an option. Not all types of spasticity or distribution of spasticity is amenable to Botox, but it's great because you don't have the systemic effects of these oral meds. Intrathecal pumps, especially with baclofen, are helpful because of the less CNS effects, but is usually reserved for patients with more severe spasticity. So the bottom line is just to say there's no preferred agent. You're balancing the efficacy versus the side effects. So I also wanted to give a few pointers on wheelchairs. And the first is that it's really a good idea to have the PT or OT involved in the fitting of the wheelchair, or deciding what type of wheelchair, what size, what features should be ordered, because the patient is most likely going to be stuck with this chair for 5 years because that's what Medicare is going to give them. And so it's really important to get the feature, the type, the features, the fit type and features right. And if going with a motorized wheelchair, they need to have some sort of assessment or testing done to make sure that they're safe to operate it. I think maybe a lot of us have seen that go down wrong when people are a little bit too, lack the safety awareness or get a little too speedy with the motorized wheelchair or running into things. If before they get the wheelchair, it's good to communicate with the therapist about any progressive changes that are anticipated depending on their diagnoses. And then their wheelchair should be looked at, about every year and as needed. That could be done by a vendor service or PTOT. There's always things breaking. There's changes that are happening with the patient. They may have lost a great deal of weight or gained weight, and the chair no longer fits. Their postural control may have declined, and they may need more postural support, may need a tilt and space chair, etc. Anytime somebody has a fall from a wheelchair, that's a red flag that they aren't being adequately supported in the chair. And anytime you're hearing about a skin pressure injury, Sometimes it's the metal armrest and the things hanging out by the footrest that are putting pressure on their ankles or around their knees or other points, and needs to be readjusted. Or their Roho cushion is worn out and they need a new one, and they're having some pressure injury on their backside. So anyway, just they need to be checked out frequently, and it's good to have a PT or OT involved in that. So for our case here, with this patient with spasticity, who's 69, you try to slow cross taper over to baclofen, and it's always good to start low and go slow. So 5 milligrams TID is a reasonable starting point. And you asked the physical therapist to assess his wheelchair fit. And you found that the baclofen was kind of helpful, but not optimal. So you referred him to rehab, where he got a Botox injection with good effect. Okay, I want to switch gears and talk about dysphagia. So really common, just in the general geriatric population, it's like almost a fifth of folks, and then that number goes up with age. And I couldn't find the numbers, but I know that they're going to be much higher in this population. And, obtaining a modified barium swallow or a video fluoroscopy is helpful. And having speech pathologists help with recommendations for textures and feeding strategies, also very essential. And, just a note about feeding tubes, they can provide adequate nutrition. They're probably not going to prevent an aspiration pneumonia based on the studies that we've seen. And if you have a patient with comorbid dementia, you really want to avoid the situation where you're putting in a feeding tube in that patient. They have been shown time and again not to improve mortality, not to reduce pneumonias, not to reduce pressure ulcers, not to improve quality of life measures. So important to steer families away from that. So common other issues associated with dysphagia is just upper GI dysmotility. It's very common in this population and can lead to the dysphagia, but also reflux and gastroparesis. So patients may suffer dental erosion, excuse me, stupid cold, esophagitis, anemia, feeding problems, and aspiration pneumonia. Okay, I'm going to try a cough drop. A third bottle?
Yeah.
I'm okay, thanks. Sorry, everybody. Okay. In lower GI dysmotility, we're talking about constipation. So this is exceedingly common, about 40% of intellectually disabled patients. Really
40% is 0.4.
weird. Okay. Thanks, phone. It's most often due to immobility and lack of exercise. Psychotropic meds are contributing, anticholinergics, opioids. And if it's not detected or not treated, often will lead to fecal impaction and bowel obstruction. A constipation diagnosis is easy to miss, and it's a common cause of patient distress. So when history is limited, it's okay to shoot an abdominal plain film to get an idea and look and see what's going on in the belly. Bowel regimen, and there's a million different ways to do it, is important, and hydration and activity are key. So there's an abdominal plain film, FOS, full of stool. Osteoporosis, these patients are at a much higher risk due to their immobility and wheelchair dependence, nutritional deficiencies that they commonly suffer, exposure to anticonvulsants, and their low vitamin D levels and more time spent indoors. Routine DEXA screening is important and unfortunately often forgotten, honestly. And important, of course, to replete the vitamin D levels before initiating therapy with bisphosphonates due to the risk of hypocalcemia. Bisphosphonates are still the first-line therapy. You're more often probably going to be using IV forms due to dysphagia or inability to follow directions to sit up for 30 minutes, or just those upper GI dysmotility issues that are so common. Important to address dental issues. Recent studies have shown that, if dental extractions or implants are planned, it's probably okay to continue bisphosphonate therapy, but it's reasonable to withhold up to 2 months before the procedure and then wait until the bone is healed before resuming bisphosphonate. Polypharmacy, very common in this population. You got a lot of prescribers. You've got the primary doc, you got their neurologist, their mental health nurse practitioner, their urologist maybe for their chronic Foley, etc. The highest number of drugs seem to be taken by nursing home dwellers. And psychoactives for behavioral issues often get left on the list even when we couldn't tell that they were necessarily effective or helpful. And a caregiver may not understand the medication's purpose to bring it up and ask if it needs to be continued or not. And so it's important to review these meds regularly and reduce or eliminate them whenever possible. And then a note on pain also. So the presentation of pain may be atypical in the patient with an intellectual or developmental disability. They often don't show the usual signs of pain expression that we rely on. They may not be able to grimace. They may not be able to verbalize or localize. They may not cry. Those with central nervous system abnormalities or spinal cord abnormalities might not be able to spike their blood pressure or pulse. So all of those typical things that we look at or look for might not be there. So you do have to, in many cases, use the instincts and observations of caregivers and family to tell you what they've observed, what they know. How does this patient express pain? It may be repetitive behaviors or something else that you wouldn't have otherwise anticipated. So it's important to ask about behaviors, activities, or change of activity, less engagement with activities, change in their affect. Has their mobility decreased? Are there any disruptions in sleep? And even verbal patients may not have the cognitive ability to localize or describe their pain. And so that work falls on you to investigate and figure out. So the basics, for things like musculoskeletal pain are to use heat, cold, and stretching, etc. Consider PT referral. PT referrals can get a little dicey in someone with significant cognitive impairment because they're obviously not going to be able to continue a home exercise program on their own. But if you have a caregiver who's engaged and someone who's willing to attend appointments with the patient and do therapy exercises with the patient, then you can get pretty good success. Excuse me again, sorry. Consider always Tylenol, especially on a scheduled basis, if you can presume that pain is present. Avoid NSAIDs. Our geriatric patients do the GI and renal side effects, so you're going to want to avoid the ibuprofen and naproxen. And muscle relaxants, as we talked about earlier. If they have neuropathy, you're going to want to look at gabapentin or pregabalin, even venlafaxine or duloxetine. And avoid the tricyclics if you can. They're anticholinergic. If you really have to use one, lean to nortriptyline instead of amitriptyline, as it's less anticholinergic. And always go for the lowest effective dose of opioids. Patients, many are hesitant to use opioids, and the end result is that a lot of our patients are undertreated for pain. I'm often, I would much rather use, 2.5 milligrams of oxycodone TID than, 600 of ibuprofen. I think the risk profile is much less. And as I talked about, using scheduled medication if pain is presumed, just to address the pain in a patient who can't reliably communicate their pain and if they need a medication. So here's a patient of 74 years who's with dementia and some paranoia, living in an adult family home. You get a fax note from the adult family home operator that she's agitated and striking out at staff and other residents for the past week. And the operator is asking if she could come in and get a UA and maybe some PRN Ativan, as she's been less redirectable lately. So behaviors. Communication barriers make evaluation of behaviors really difficult. But it's important to remember that behaviors often are just an expression of pain, anxiety, or some need for attention. And that any change from baseline behavior, we should be looking for pain, with constipation being a common source of pain, delirium, evidence of abuse, medication side effect, signs of anxiety or depression. And please don't, whatever you do, just get a UA without any signs or symptoms of a bladder infection. As most of you know, that asymptomatic bacteriuria is commonly misdiagnosed as a UTI in the setting of behaviors. So it's important when you're evaluating these folks to do a really careful physical exam, looking first for a source of infection, respiratory, skin, and urine. If they have suprapubic pain or flank pain, yes, go ahead, please get a UA. Or if they have a fever. If they have source of pain from looking for any evidence of trauma, skin breakdown, constipation, reflux, dental issues, or musculoskeletal injury, spasticity or fracture, kidney stones, testicular torsion, etc. And studies that you might obtain, a chem panel, might look for thyroid, might look for anemia, you might be getting x-rays, kind of the basic things that you would do with anyone who's unable to communicate their source of pain. So management of behaviors. It's important to look for patterns in behaviors, any new stressors or triggers, any interpersonal conflicts, especially with new caregivers, or any disruptions in sleep. Resist the temptation to throw a medication at something and instead try to figure out where this behavior is coming from, and enlist the help of folks of other disciplines, because it's the only way to really successfully go about caring for these patients. Antipsychotics are commonly used. They should be reserved really for resistant serious behavior. So someone who's having, you've ruled out any reversible cause and you're left there with a behavior most likely due to underlying psychiatric disease. You want to definitely wean to the lowest effective dose. And, with the newer atypicals that we're commonly using for these folks, it's you got to monitor for metabolic syndrome. You got to be checking their weights, their blood sugar, their blood pressure, their lipids. If you're practicing in a nursing facility, you're going to get cued by the pharmacist, and then some to monitor these things and to also do gradual dose reductions or tapering off of them whenever possible. But if they're out in the community, these medications can hang out at pretty high doses for years without any attempt to reduce them and see how the patient does on a lower dose, or to take them off and see how they do. So you have to kind of remind yourself of that. So here we are again with the 74-year-old woman who's been hitting folks at her adult family home and they're not happy about it. So you had her brought into clinic, or maybe you went out and did a home visit, and you learned that her oral intake was decreasing lately due to increased paranoia. And she didn't have any complaints of dysuria, frequency, or hematuria. Her mouth was a little dry on exam, and she had been passing very small, hard stools. Her belly was firm and tender. She didn't have any suprapubic pain or fever. And, excuse me, so she was diagnosed with constipation. And you address that by increasing her bowel regimen and work with the patient and caregivers to increase and monitor her oral hydration. All right, should I try to answer some of these questions? I don't know. I can't, or wait till the end? Or,
You're welcome to, however.
okay. Right.
You want me to read some of them?
Oh, no, yeah. Well, can everyone see them, or do I need to read it out loud?
Well, I'll read them to you. How's that?
Okay.
We can go over that. So, Brent mentions that dantrolene will also make the patient appear drunk. I don't know if you have any more comment related to that.
Yeah, I mean, they're all, CNS active, so it can.
You might want to repeat my question.
Oh, they can't hear
might
you.
not be able to hear.
Okay, so the question was, the statement was that dantrolene can make people appear drunk. And I would say, yes, with any of these muscle relaxants, they do have a central effect and can make someone altered for sure.
So Missoula is asking you to please discuss reimbursement issues when a person goes on Medicare and is on Medicaid. People with dual insurance often have more complex issues with funding, especially for durable medical equipment, et cetera. What else does it impact, and how have you addressed these issues with primary versus secondary payers and dental, I'm assuming in this particular patient population?
Yeah, I don't know that I can necessarily speak with any sort of authority on the
Dual eligibles?
the dual eligibles on the financial side. Yeah, I'm sorry, I don't want to. I'm probably at the same thought process where the person asking the question is.
So we might, if you guys can't hear me, let me know, but you might take a look at May Reed's lecture that she gave at the beginning of this series on the Affordable Care Act and some of the issues related to that and how dual eligibles fit in. Actually, all of the policy lectures that we've done, because we have lectures from the AAAs.
Oh, yeah, great. Yeah.
Okay, then Brent is saying when it comes to pain, especially for those with CNS damage, they may not be able to even feel the pain until they've reached the point when it is affecting them physically. So watching these people particularly closely for even minor changes that might indicate pain is probably a good idea. Do you have other thoughts on that?
I would agree that that's true. That especially if there's a significant brain or spinal cord injury or disease, that the message may not be able to reach their awareness until it's pretty severe.
What is the relationship between dementia and UTIs?
Well, I don't know that there is a great one. I mean, other than, folks with dementia have increased risk of, poorer perinatal care, higher risk of incontinence that can increase their risk of UTIs. I would say it does make it harder to diagnose when they can't report symptoms, so you are relying more on the physical signs of UTI. Yeah. Okay.
Any questions here in the room?
A lot of pressure on two people. Okay, let's see. As well as a decreased thirst drive, right? So those with dementia have a decreased thirst drive, higher risk of dehydration, and that can cause the urine to sit around in the bladder longer and develop an infection. Okay.
So they're asking about, does a client have to have UTI symptoms to check for a urinalysis when many don't have those symptoms? So except for cognitive and mental changes, What would you guide them, I think is what they're asking.
Yeah, so-
regarding checking for UTI.
Yeah, I could send along a paper to help, but there's basically, you want to have some sign or symptom of UTI, so they need to have some pain on palpation over their bladder, flank pain, fever, could be even low grade, observed increased frequency, observed increase in incontinence. You have to have some sort of urinary symptom. Otherwise, you're just diagnosing asymptomatic bacteriuria and calling it a UTI. That there needs to be some sort of sign or symptom of a UTI to really call it a UTI.
What is the regular treatment for chronic constipation in these patients?
So it's interesting, these days, there was a study recently that showed that Docusate was common stool softener was as good as placebo, which clinically I find it hard to believe, but it's out there. So, using osmotic agents is generally a good idea. So Miralax regularly has been very helpful. Avoid, stimulants their effectiveness can wane over time. So relying on things just senna alone often will backfire over time. There's been some interesting things lately about using probiotics routinely in those with chronic constipation, and that's been helpful. But I would say, hydration, activity, and osmotic agents like Miralax or in some cases even things like lactulose, I've found have been helpful just in my clinical practice. A big teaspoon of coconut fat treats okay, I did not know that, but I believe it.
Fairbanks says Docusate keeps things soft but doesn't make you go. The osmotics may give you more bang for your buck.
Yes, as I've heard this saying, you need the mush, push, and the gush. So the mush can come from Docusate, the push senna, and the gush from osmotic agents. And some people believe in giving all three in cases like chronic opioid therapy. But I think the osmotics do give you more bang for the buck. All right.
Okay. I think
Maybe we should keep going. Okay. So I'll get back to the talk a little bit. So mood disorders, the diagnosis and treatment of psychiatric disease is often missed or delayed in this population. 3/4 of these folks are not seen by subspecialists. As we know, the access to mental health professionals or our psychiatric practitioners can be pretty limited. And the frequency of depression in institutional settings may be, or probably is, honestly, higher than it is out in the community. Seizure disorders increase risk for depression, and behavioral issues are often, those are the things that draw attention to the psychiatric problem. The patients who are suffering from depression more silently, if you will, who are more withdrawn, are often the ones that go under the radar and are not treated. Harder to ignore someone who's in your face, striking at a caregiver. It's important to remember that in this population that PTSD is going to be more prevalent because of the increased risk for abuse that they might have suffered at some point in their life. So depression, there's the three basic clusters of symptoms of depression. There's psychological, behavioral, and neurovegetative. So the way depression can manifest in these patients is, psychologically they might have more anxiety or morbid thoughts and decreased interest. Behaviorally, maybe more aggression or self-injurious behaviors. And as far as neurovegetative symptoms, they might not be sleeping as much, they might not be eating as much. And for those with more mild, moderate disability, you're going to see more of the psychological and neurovegetative symptoms. That's how they'll present. But for those with more profound disability, it manifests more often as behaviors, so self-injurious behaviors, aggression, or agitation. Both groups are susceptible to suffering weight loss, decreased activity, or increased sense of pain. Okay, so Here's another patient, 54-year-old with Down syndrome, living in low-income senior housing, and he's attending adult day health. He's presenting to clinic with his guardian, who states that she's worried about him because he's losing weight. And the day health agency also notified you that the patient's been attempting to exit seek and is less engaged with activities. And the day health case manager performed a MOCA exam, and his score was 10 out of 30, down from 15 out of 30 3 years ago. So, in this population, when you're dealing with an underlying cognitive deficit a lot of the time, the dementia is something that's going to involve a change from the prior level of functioning. So you'll have to suss this out by talking often to the family or caregiver and asking about any changes in ADLs or their ADL independence, their participation in hobbies or activities. And it can be really difficult to diagnose because of the underlying cognitive impairment that's often present. And there's no generally accepted criteria for memory or cognitive assessment in this population, but there are a couple of tools that I list there. And you can use the tools that we're more often using, the MOCA or the mini mental status exam, to establish a baseline and follow-ups. Not that it's been validated in this population or anything, but it can be just kind of a tool to use for general tracking of cognition. So just a note about Down syndrome and dementia. They are at increased risk for Alzheimer's dementia. They have a younger age of diagnosis. 20% of patients with Down syndrome over 45 years have dementia. And there's showing the PET scan, you see the bright blue areas are the abnormal brain tissue where there's plaques and and tangles present. And it's just showing basically that this young Down syndrome patient has a brain that's pretty similar to a 52-year-old control patient, and that the older Down syndrome patient has also similar distribution of abnormal tissue to a patient with Alzheimer's disease. So Alzheimer's dementia pathologically is characterized by the neurofibrillary tangles and beta amyloid plaques everywhere. And the gene for the precursor protein for the beta amyloid plaques is on chromosome 21, so it makes sense that when you have 3 copies of it, you have an excess production of it. And then on top of that, there's another gene for superoxide dismutase, which is basically something that helps to reduce the free radicals and things. So when you have 3 copies of chromosome 21, you're going to have more free radicals and more damage happening. And so this is a really, I'm grossly giving the general overview of why it's common in this population and at a younger age. So for this patient who's at home and losing weight and not doing well, on further questioning, you found that he's really unable to cook for himself now, and his apartment's in disarray. And you discussed moving to an assisted living apartment where he can get some meals and more supervision. And he's going to continue to go to day health for social engagement, exercises, and nursing care, and also, I guess, weight monitoring, etc. And you might be discussing a GPS monitoring device, depending on the amount of supervision that's available at the assisted living. And cognitive testing was done just to compare to his prior testing. Okay, so I have my true-false questions. Should I give them now, or?
You can, although
Okay.
We just put them on the website for the
Okay.
continuing education credit. So it's
Okay.
up to you.
Is it okay if we do it
Sure.
with the answers now? And
Sure.
Okay.
Sounds like
They're
fun.
pretty straightforward. So, number 1, all individuals with a developmental disability also have an intellectual disability. True or false? Anyone? Well, I guess people can type
Yep.
as fast as they can.
Are you able to see the?
False, right? Okay. Adult family homes and assisted living facilities are pretty much the same thing. False or flass. Nonverbal or severely limited patients are at greater risk for poor nutrition, over-medication, injury, and abuse. True. Yes, if a patient is deemed to lack decisional capacity regarding complex medical decisions, they should not participate in any decisions regarding their care. False, right? And healthcare disparity is common due to the increased burden of disease, communication problems, and inadequately funded support services. True. Okay, there they are. And then I did 10 because I thought I was supposed to do 10.
Yeah.
I apologize. So all antispasmodics have similar efficacy and side effect profiles. True or false? False. For nonverbal patients, assess pain by measuring blood pressure and pulse. False. It's a good idea to always obtain a UA when a patient presents with agitated behaviors. False. Thank you very much. Profoundly disabled patients are more likely to present with behavioral symptoms in depression. True, yes. And 20% of patients with Down syndrome over 45 years have dementia. True, yes. Okay. All right, thanks. There's me and all the nurses from Full Life Care Adult Day Health from a couple years ago, having a good time. And there's references for everybody. Okay. So yeah, Q&A or?
Yeah, any other questions from the sites? One person is asking for the paper, so if you want to send that to me, I'll see it gets out to the sites.
Which paper?
You said about the UTI?
Oh yeah, yes. Yep, I'll write a note to myself. And that was mainly for folks living in long-term care settings.
Oh, here, is
Thanks.
the higher rate of dementia mostly seen in individuals with Down syndrome or other developmental disabilities, intellectual disabilities? Do they also have a higher rate?
They do have also a higher rate. I can't tell you specifically numbers, but it is a risk factor for developing dementia.
All right. I guess that's it then.
Okay.
Thank you so much.
Great. Thank you, everybody.
Appreciate it.
Yeah. Thanks.